Hello, and welcome to the Medical College of Wisconsin's community briefing regarding the COVID-19 vaccines. I'm Greg Wesley, a Senior Vice President here at the Medical College of Wisconsin. We're grateful that you decided to join us today. I'm going to repeat that. We're deeply, deeply grateful that you've joined us today. Our goal is to bring the community up-to-date information, accurate information regarding the COVID-19 vaccines, and to answer questions so that you can make informed decisions that best take care of your family, yourself, and your community. This webinar will consist of about 15 minutes of presentation, followed by 30 minutes of Q&A. 15 minutes of presentation, 30 minutes of Q&A. We want more Q&A than presentation because we want you to be able to make the most informed decisions you can about the COVID-19 vaccines and to answer your questions. We have experts hosting us today. Dr. John Raymond, President and CEO of the Medical College of Wisconsin, and Dr. Laura Cassidy, Professor and Director in the Division of Epidemiology here at the Medical College of Wisconsin. It's my pleasure now to turn it over to Dr. John Raymond to go forward with the presentation. Thank you.
Yeah, thanks, Greg. We really do appreciate everybody's being here. It's such a timely topic and important. And Greg, thank you so much for the introduction and the reminders to keep the slides brief. If we can go to the next slide then. I'll start just to give you some basic information about where we are with COVID-19 in Wisconsin and Milwaukee. Starting on the left, you can see that 2.7 million people have been tested for COVID since the beginning of the pandemic. That's almost half the population of Wisconsin. And in Milwaukee, we've had over 400,000 people tested. Going down a little bit on the left-hand side of the slide, you can see that we've had almost 450,000 cases of COVID-19 in Wisconsin since the beginning of the pandemic in March. And almost 79,000 of those have been here in the Milwaukee region. Going to the right-hand side of the slide, I want to talk about the daily positive cases as reported by the Wisconsin Department of Health Services yesterday. We had about 2,400 cases. That's a lot of cases, but it's significantly improved from mid-November when we were averaging over 7,000 cases a day. 389 in Milwaukee, again, relatively light compared to where we were in November when we were averaging almost 1,000 a day. The case positivity remains high. In other words, what that is the percentage of people who are tested who test positive. So we have about a 25% case positivity rate. Ideally, you want that to be below 5%. So this means we're probably not testing enough people. Part of it may be that people don't want to wait in line to get a test, and they're concerned that they might not get the test back in a day or two and that it wouldn't really be of any benefit to them. What I can say is the waiting lines at a lot of the remote testing sites are very short now. We have good capacity and we're averaging a one-day turnaround time. So if you have any symptoms or you've been exposed, it really is best if you get tested. Next slide, please. On this slide, I just want to talk a little bit about hospitalizations. We've had almost 20,000 people hospitalized in Wisconsin since the beginning of the pandemic with COVID-19. We have improved in terms of your likelihood to be hospitalized. In March and April, if you had a positive COVID-19 test, you had about a 30% likelihood of being hospitalized. And that's down to 4.4% now because we know a whole lot more about how to treat COVID-19 and to prevent people from having to come in the hospital. We still have a lot of inpatients in Wisconsin with COVID-19, 1,410 yesterday, but that is declining. We are down 125 compared to the same day last week. But our high was almost 2,300 back in the middle of November. And just to put this 1,400 number into perspective, during most of the summer, we were ranging between the low 200s and 300 on most days. So we're sitting here 4 or 5 times higher than we were in the summer. So still a lot of hospitalizations from COVID-19 and a lot of patients in the ICU. As you can see on the lower left, in Wisconsin, we have 314 patients in the ICU with COVID-19. And that's trending downward, but not quite as quickly as the hospitalizations. And you can see that our high was 456 in the middle of November. This is actually still a problem for us because our intensive care unit censuses remain high. That means that the ICUs operate much less efficiently. And if our staff are out sick, either with COVID-19 or with an exposure, and then they're being quarantined, it puts a lot of strain on the system. So whether you have COVID-19 or not, we all have really a vested interest in making sure that we don't fill up our hospital beds. If you go to the upper right, we only have about 235 ICU beds immediately available in Wisconsin. That's suboptimal. Throughout the summer, we were running at about 400 available beds. Ventilators, I want to make sure nobody's worried about our ventilator capacity. We have plenty of ventilators. That's never going to be a problem for us in terms of taking care of COVID-19. And then personal protective equipment. As you know, we've had a big surge here in Wisconsin through October and November. And so our supplies are running a little bit lower than we'd like, and we're critically short of gowns, paper masks, and as of yesterday, goggles. So we need to pay attention to that. Next slide, please. 89.7% of the patients who've been diagnosed with COVID-19 in Wisconsin are designated as having recovered. And I want to make sure that you understand what that means. Recovered, the definition of recovered for the Department of Health Services is either 30 days after a positive test or substantial but not necessarily complete resolution of symptoms. And this is important because up to a third of patients who've had COVID-19 have residual or persistent symptoms like brain fog or severe fatigue, for example. And in fact, this problem is so significant that many medical centers are setting up clinics for people that have not completely recuperated from COVID. Our death rate in Wisconsin is 0.9% from COVID-19. That's better than the national average, which is running about 1.8%. On the other hand, I want to make sure everyone knows that's 10 times higher than the influenza death rate in a bad year. And just earlier this week, the number of COVID-19 deaths in the United States in 2020 exceeded the number of deaths from cancer and heart disease. So COVID-19 is a leading cause of death in the US right now. Draw your attention to the center part of the slide. We've had almost 4,200 deaths in Wisconsin from COVID-19, and nearly 800 of those are in Milwaukee. Slight male predisposition for bad outcomes with COVID-19. That's been very consistently seen since the beginning of the pandemic. I also want to draw your attention to the bottom part of the middle panel. I want to highlight that people of color are disproportionately impacted by COVID-19, more likely to get COVID-19, more likely to be hospitalized, and more likely to die. There's an overrepresentation of deaths of African Americans and Hispanic and Latinx individuals compared to the overall population of Milwaukee and Wisconsin. So that's why it's really important when we think about the vaccine. We need to address vaccine hesitancy and build trust, especially in communities of color. I'll skip the right side of the slide. Just want to say that our numbers in terms of the trend lines look okay, but not great. And in particular, we want that reproductive number in the bottom right to be much less than 1 if we're going to really get control of the pandemic. Next slide, please. So people have asked, are we having less COVID-19 now than we were having in October and November? And have we seen a Thanksgiving surge? So let me start by saying we have not seen a surge after Thanksgiving here in Wisconsin, but pretty much the rest of the country is seeing a surge, especially in the Sun Belt and on the East Coast, probably because we had a huge burden of disease. For about a month, we were what I would call the epicenter of COVID-19 in the country. And so Wisconsin case counts are declining, hospitalizations are dropping, ICU census is dropping, and that reproductive number, the measure of contagiousness, was significantly above 1, which was bad. But for the last 4 weeks, it's been at or slightly below 1. One problem, though, is everyone needs to understand that deaths lag new cases by about 5 weeks. and we still have a lot of people dying from COVID-19. Our 7-day average yesterday was 44 deaths per day. And obviously, this is something that is troubling and is likely to continue throughout the rest of this calendar year. Next slide. On this slide, I just want to talk about why is the pandemic slowing down here? There are a couple of reasons. I think the most important is that many people are probably being more careful about protecting themselves. When your intensive care units fill up, your doctors and nurses are getting sick, and you may have a relative or loved one who's in the hospital, it's natural that people would be more diligent. There's also this hypothesis or an idea called the low-hanging fruit hypothesis. In other words, that the most susceptible people, people most at risk, have already gotten infected. And that would either be medically high-risk groups, frontline essential health or frontline essential workers, and people that weren't exercising caution. And then finally, there's this idea called the network hypothesis, that sociable people, people that interact with lots of other folks, they may be at an intersecting point of social networks. Maybe they were infected and they were sidelined, so they couldn't spread COVID-19 from one group to another. We do not have herd immunity. I want to point that out. We're not anywhere near close to having 70% of the population who've been infected. It's probably more in the range of 20 to 30 in Wisconsin. And infection is not our pathway to herd immunity. Vaccination is. This is not likely due to less testing, even though we're doing a little bit less testing, because our hospitals still have a lot of patients in them. Next slide, please. Now I want to switch to talking about vaccines. I have to say the 2 vaccines that are coming to market are much more effective than we ever would have dreamed or hoped for, and they appear to be safe. So I just want to start out by making sure that those are the 2 takeaways. So the Pfizer vaccine received emergency use authorization from the FDA last week. As you know, yes, last week the vaccine was starting to be administered in the United Kingdom, and this week in the US. The Moderna vaccine, which is based on the same technology, messenger RNA technology, it should receive emergency use authorization this week. It's passed every barrier except CDC approval, which I expect to happen within the next 24 to 48 hours. So we'll have 2 vaccines that we'll have available next week. I also need to point out no single drug company is going to be able to meet the short-term demand. If everyone in the US wanted to be vaccinated, and these are 2-dose vaccines, there are 350 million people in the US, so we need 700 million doses. Because this is a relatively new technology, there isn't the manufacturing capacity to scale up quickly. So we may have 100 or 200 million doses by the spring, but that's not enough for our whole country. The good news is there are multiple other vaccines that are likely to come to the market and receive that emergency use authorization over time. And in particular, I expect the AstraZeneca vaccine to be available in January, and the Johnson & Johnson vaccine hopefully to follow shortly after that. And our country is developing a strategy and a framework to ramp up the production and the distribution of these vaccines. Next slide, please. So I just want to talk about the prioritization for vaccination, and we're following guidance from the US Centers for Disease Control and Prevention and our Wisconsin Department of Health Services. So Group 1A is healthcare personnel and residents and workers of nursing homes and other long-term care facilities. Now, to put this in perspective, we have 50,000 doses of Pfizer vaccine in Wisconsin, but we have 400,000 healthcare providers and about 50,000 people who live in or work in nursing homes. So at least for the next few weeks, possibly a month, we will not be able to give the first dose to everyone in that category. The next category is probably going to be essential workers. In other words, people in factories, people driving buses and working in the transportation sector, people that work in restaurants and grocery stores, etc., would probably be the next group. And then we're hoping that they can all have the vaccine provided to them by late March, maybe even earlier than that. By mid-March to late May, we hope that there will be vaccine available for people with high-risk medical conditions, the elderly or people over 65 who are more likely to get COVID, and at-risk communities. There's an ongoing discussion now about how do we get the vaccine into communities that have been impacted the most by COVID-19, in particular, African-American neighborhoods, Latinx neighborhoods, Hmong neighborhoods here in our region, and Native American reservations. So there's been no decision yet, but we're lobbying hard to make sure that those communities get high profile. And then after that would be the general population. Next slide, please. So will the vaccines be safe? Yes, they're very safe. What I want to make sure people know is that the safety and effectiveness of the vaccines has gone through the usual process with external objective peer review by scientists, ethicists, and infectious disease experts. It's gone through the usual regulatory processes by the Food and Drug Administration, but the process has been shortened very much because of the urgent need to have the vaccine. Amazingly, both the Moderna and the Pfizer vaccines had no serious adverse events reported in the phase 3 trials. And that was of 30,000 patients that received the Moderna vaccine. I'm sorry, half of them received the vaccine, half received saline, and 43,000 patients in the Pfizer trial. So that's a lot of patients. They were studied for at least 5 weeks with no serious adverse events. What was also quite remarkable was that the vaccines are incredibly effective. They give 95% protection. And what that means is that for symptomatic infections, if 20 people who did not get the vaccine were infected, only one person with the vaccine was infected. So really, really remarkable protection that we've seen there. Also, more good news. The studies demonstrated that these vaccines were incredibly effective for all ethnic groups, Asians, Black and brown people, white people, every adult age group over age 18, especially elderly, and people with existing comorbidities. So that's good news for all of us. Now, I do want to acknowledge that there's not been comprehensive testing on pregnant women or children under 18. They did not exclude women of childbearing age, so some women did become pregnant during the trials, and those studies are ongoing now. What I can tell you is that the American College of Obstetrics and Gynecology yesterday recommended that pregnant women should not be excluded from getting the vaccine. So women who are pregnant or lactating, breastfeeding, should talk to their doctors and shouldn't necessarily just say, I'm not going to get the vaccine. If I could go to the next slide, please. So what to expect if you get the vaccine? Like the flu shot, it's given in your upper arm. And as I mentioned earlier, these two vaccines that are going to be on the market require 2 shots. For the Pfizer vaccine, the second shot is given 3 weeks after the first, and for the Moderna vaccine, 4 weeks after the first. Like the flu shot, after you get the vaccination or the shot, you'll have a response. You may have a sore arm, tenderness at the injection site, redness or swelling, and some pretty significant systemic symptoms like fever, fatigue, muscle aches, joint pain, and nausea. Those generally go away within a day or two. This is not a sign that you've become infected. These vaccines do not have any virus. So the reason that you're going to have these symptoms is because your body is building immunity. Now, it takes several weeks after receiving the second injection for you to achieve your best immunity. So we're really talking about somewhere between 7 and 10 weeks after the first shot. I also want to make sure that you know that getting 1 shot gives you some protection, maybe 50%, but you're going to get that best protection if you come back and get the second shot. And the state has set up notification systems to remind people to come and get their second shot. And we also need to understand that until at least 70% of our population have been vaccinated, we're going to need to continue to have precautions like the 3 Ws, wearing a mask, watch your distance, wash your hands, and only do essential trips outside of your home and minimize the number of people that you interact with. And this is really important for us to remember with the holidays coming up. Next slide, please. So it's important that all of us get the vaccine. And I'm going to turn this over to Dr. Cassidy.
Thank you, Dr. Raymond, and thank you for all of that really important information that I know people have been wondering about and presenting it in a way that's so understandable. This slide is a little funky, but I'm going to build upon that and talk about one of the major goals of vaccination is to acquire herd immunity. And herd immunity is a term that epidemiologists use a lot, and I haven't heard used as much ever as it's being used now. But one of the reasons COVID-19 became a pandemic so quickly is because it's a new virus and nobody was immune to it. None of us had built up immunity or been exposed to it, and everybody was susceptible. And it's passed through human interaction, so it passed very quickly across the globe. So when we talk about herd immunity, what we want to achieve is enough people vaccinated against the virus so that it can't spread quickly. And the best way to achieve that is through vaccination, not through natural immunity by acquiring the disease. It's the safest and most effective way. So when most of the people are vaccinated, the virus has nowhere to go, and it can't travel as easily from person to person. And so this really provides community protection. And that's what's important. And even if we get to those rates that everybody suggests that we want, over 70%, it doesn't mean that people should necessarily wait and say, I'm just going to wait, and when there's herd immunity, I'll be safe, because you'll still be vulnerable to the virus, you'll still be at risk, and you'll still be able to spread it. So it's a goal to protect those who can't get the vaccination yet for some reason. And as Dr. Raymond mentioned, it's important to note that the vaccine won't be available for children right away either. They will be one of the last groups. So the more adults who can get immunized through the vaccine, the more we protect our children until it's available to them. And one of the important points too is early on in the pandemic, studies suggested that people reporting only about 40% of the population was willing to get a COVID-19 vaccine. And now more people are reporting that they're willing to take the vaccine. And so the community acceptance has grown, and that will help us achieve community protection. Next slide, please. The CDC has laid out a vaccination framework for approaching this, and it's based on principles of protecting communities, empowering families, and stopping myths. So, as I mentioned with community protection, a campaign to get people vaccinated, protect them, and stop the spread of disease. And even if overall we achieve high rates of immunization, if there's pockets of the community who aren't willing to take the vaccine or can't, they'll still be vulnerable. So there could be specific geographic locations where vaccination rates are low and those communities are still vulnerable. So it's really important to use data to drive our vaccine campaign and our vaccine initiatives and make sure that everybody has equitable access to the vaccine. And we want to be able to distribute it in ways that are easy to access. And this will grow over time. You know, right now they're starting with hubs across Wisconsin and a wheel and spoke type of distribution. Part of that is because of some of the challenges with the Pfizer vaccine needing to be in such cold special freezers, which Moderna can use. Moderna doesn't have that requirement, so it'll be more easy to get that vaccine and future vaccines to rural communities and low to middle income countries and places that don't have those super freezers. And so being able to communicate with your physicians is important. And there's a lot of misinformation out there and myths, and it's been a scary year. There's been a lot of changes. There's a lot of people who have suffered greatly in many different ways from this pandemic. So it's important to recognize that. And if you are fearful, if you are scared, if you are concerned, it's okay. I mean, this has been a really hard year, but feel comfortable reaching out to your healthcare provider or to reputable sources and ask questions. We need people to ask questions. We need people to understand. And we're trying to get accurate and timely information out to the public so people do feel comfortable and they can make informed decisions for themselves, for their family, and for their community. Next slide, please. And so when we talk about some of the myths that are out there, I was going to do Mythbusters, but I couldn't even bring myself to type some of the myths. But, you know, there is, and especially with social media, things get blown out of proportion or stretched or misinterpreted. And so to put some of these, to clarify some of these, COVID-19 vaccines will not give you COVID-19 or the flu. It's not a live virus. You're not being infected with the virus. So like Dr. Raymond mentioned, you may experience some symptoms that indicate that your body is working and fighting the virus. And what it does is it prepares your body to recognize the virus and have the immunity to fight it. Vaccines do not contain toxic ingredients. It's such a small dose, and the amount of things used in it are so small, there are no toxic ingredients in it. Vaccine-induced immunity is safer than natural immunity. So if you've had COVID-19 and you've recovered, it's much safer to be vaccinated against the virus than it is to have the feeling that if you just get sick, you'll be immune to it. It's safer, it's controlled, it's training your body and teaching it to respond. Just like if you're training for an athletic event, you need to train and teach your body how to respond. And if you do actually get COVID, there are much more severe consequences. You may get very ill, you may end up in the hospital, and that's much more severe and more difficult on your body than getting the vaccine to keep you safe. The flu vaccine does not protect you against COVID-19. It protects you against the flu. They're both respiratory viruses, but they're different respiratory viruses. And vaccines are so specific that they target what they're intended to target. Now, getting the flu vaccine will keep you healthy. And if you do get sick, you know, it'll help prevent the flu, which is good, and it'll keep your immune system healthy. So that is a good thing. And even if you've had COVID-19, you should still take the vaccine. If you're actively ill, you should wait. You should not go out in public. You should not put other people at risk of exposure. And the current guideline is to perhaps wait 90 days until after you've recovered to take the COVID-19 vaccine. And importantly, the vaccine does not alter your DNA. And they're not created with the use of fetal cell cultures in the production process. So these are things we've read and we've been asked. So I just did want to clarify some of these topics with everybody. And having said that, next slide, please. I believe we're open for questions. Thank you.
Thank you, Dr. Cassidy. This is Eric Johnson. I have a poll.
Yeah, go ahead. I just wanted to clarify, I got an email that the numbers I was reading were different. So I apologize. I was looking at an earlier version of the slide deck before we plugged in yesterday's numbers, but the main points remain the same. So again, my apologies.
So Eric, we have questions. If you could feed the questions in topical order, I'd appreciate it. Thank you, Dr. Raymond and Laura.
Thank you, Mr. Wesley. Yes, we actually have a poll before we go to questions. So I'm going to throw the poll up on the screen right now. Do you plan to get the vaccine? Yes, no, or not sure are your options. And with almost 500 people in live attendance, I'm hopeful that we can get several hundred responses back on this. I'll give you a little update here. We're at 3% now, so I know we can do better than that. 5%. 10%. I'm going to leave the poll open for 10 more seconds, so go ahead and get your vote in if you're comfortable letting us know. 26%, 40%. All right, poll will be closing in 5, 4, 3, 2, and 1. And with 76% voting, here are your results. 82% plan to get the vaccine. 5% no, 13% not sure. So we'll go to questions now. We have a lot from the audience, and I want to remind the audience who weren't able to find the questions panel, keep them coming throughout. We've got a whole team of people editing those questions, getting them sorted by topic. We're going to open with a question from Angela. I'm confused about efficacy. If the vaccine is 95% effective, does that mean 95% did not get COVID-19 and about 5% did? Or does it mean 95% either did not get it or only experienced mild symptoms and the remaining contracted COVID and experienced more severe symptoms? Dr. Raymond, I think you're muted. I'm sorry, sir.
Thank you. My apologies. The 95% reduction doesn't mean that 5% of the people that got the vaccine were infected with COVID-19. It was actually a lot lower than that. What it means is when you compared people that got saline versus people that received the active vaccine, 20 times more people that got saline had an infection compared to the people that got the vaccine. So that's where you get the 95% reduction number. And I also would like to make clear what this meant. These two studies only examined people that had symptoms. We don't know whether the vaccines prevent having COVID-19 with no symptoms. And that's important. It gets back to why we have to wear masks, because most of the spread happens from people that feel fine. And so that's something that Pfizer and Moderna are going to try to answer in January and February.
Next question is from John. Are we overstating effectiveness greater than 90% of the vaccine since those vaccinated in the studies were not directly exposed to the virus after vaccination?
Well, I guess, thank you, John. No, I don't think we are, because basically you're comparing to the transmission and the burden of disease in the communities in which the people receive the vaccine. And the control folks that receive saline were from the same communities, had the same demographic background. So there was an internal control. So it is 95% effective in the community, measured 1 week or longer after the second shot. We just don't know how long that protection will last.
Thank you, Doctor. 3 more questions. These are all from Jennifer in advance of the webinar today, and I think they're clustered together pretty well around access to the vaccine. So I'll ask the first one. Will there be official documentation provided to those completing the vaccine protocol to use as proof of vaccination?
I don't know that a decision has been made about that yet, but there is a pretty good discussion ongoing about the usefulness of having the vaccine certificates. You know, off the top of my head, I would say it's probably a good idea, but we're not really sure how you would use that, the certificate. But there's an ongoing conversation about it. So the answer will be in the next few months.
Jennifer's next question was, can a family member who is the caretaker of an elderly parent get the vaccine earlier?
I think you could make a good case for that, but right now I don't believe that that's been in the conversation. And again, the CDC really hasn't given firm guidelines about what would be 1B and 1C categories. But if that's important to you, I would make sure that you let your local public health officials or your elected officials know so that they can influence that process.
Jennifer's third question is, how will the elderly who live at home be contacted about getting vaccinated? Where is vaccination likely to occur?
Vaccinations are going to happen in many places. Right now, they're limited to clinics and hospitals. But we're hoping, what we know is CVS and Walgreens are going to be going into nursing homes to administer the vaccine over the next month or so. And we're pretty sure that there might even be drive-through sites that get stood up early next year. Just in terms of communication, that's really a good point. And we're going to hopefully be able to rely on word of mouth from people within their networks to get to folks that maybe don't have internet and don't get out of their house very often. Dr. Cassidy, did you want to add anything? Okay.
Next question is from Laura in the audience today. Is there sufficient research on the side effects of either COVID vaccine on the elderly? I have grandparents in their 90s and none of them feel comfortable getting vaccinated yet.
Well, I guess it depends on your definition of sufficient, but there were thousands of patients, many of whom were elderly, who did receive one or the other of the vaccine, and they didn't have any significant side effects compared to the saline group, or in fact, any significant side effects compared to the younger age groups. So these vaccines, again, not only being more effective than we could have even hoped for, but also appearing to be very, very safe for everyone.
And especially with the elderly, I think you have to balance the benefit versus the risk, because their risk is so high and the benefit is so big. So great.
Next question is from Terry, who's in the audience today. Have there been any adverse or allergic reactions to the vaccine so far in Wisconsin?
Not that I'm aware of, but thank you for the question. It's important to highlight that in the United Kingdom, 2 healthcare workers who had a previous history of severe allergic reactions did have allergic reactions when they took the first shot, and those happened almost immediately. They had epinephrine pens, so these were people that knew that they had significant allergic risk. They both recovered using pretty standard treatment, epinephrine, a steroid, and a histamine blocker, Benadryl. There was a 3rd healthcare worker in Great Britain who had a rash and some wheezing, and they were treated the same way. And 2 people in Alaska, one of whom had to be hospitalized because they had a high heart rate and a low blood pressure, but they're recovering. So I think it's important to make sure that if you carry an EpiPen, if you have a history of a severe reaction to either a medication or to food, if you're in a high risk group and you're going to get the vaccine, it should be under supervision.
Next one's from Lori. If you don't experience any symptoms when you get the shot, does that mean it isn't working?
No, it doesn't mean that at all. And in fact, there are years when I get the flu shot and my arm doesn't hurt and I'm fine, and other years where I have a fever and the aches. So no, it doesn't mean that at all.
We have a few questions about students next. From Jennifer, how likely will it be that college students wanting the vaccine and needing it for participation in specific summer programming will be able to get it by May?
Well,
I think they will. Yeah, go ahead, Laura.
The current projections is that the vaccine will be available to the general public in May, but again, not everybody will be able to be vaccinated at once. So there is opportunity, but it's a little bit difficult to predict.
Next question's from Michelle. Can you speak to research on COVID-19 in children under 10 and transmission in schools?
Yes, there's pretty significant research that suggests that children under 10 have lower likelihood of passing the virus on to other people in their household than children over 10, maybe 50% reduction. That doesn't mean zero risk. We're not sure we understand why, and that even seems to apply when kids have a lot of virus in their nose or their mouth, a high load, maybe 50% less likely.
And from Kelly, also wondering what recommendations will be for schools and students getting vaccinated.
I don't know yet. Dr. Cassidy, have you heard anything from our colleagues at some of the other schools?
Well, we have a work group right now consisting of people from MCW, the health department, the schools, and they're evaluating the literature on that. I would imagine that they're going to be recommending vaccines for children when they're approved or authorized.
I do know that both Pfizer and Moderna are starting a study arm that includes children under 16. And hopefully we'll have the results sometime in the early 2021.
Next question is from Anonymous. How long does the immunity last? For example, is this the biannual vaccination, annual, etc.?
We don't know. I think based on the the vigor of the immune response and the protection that people get, we're hoping that it will last at least a year, but it's possible an annual booster might be required. We don't think COVID-19 is going to go away. It's probably something that we're going to be dealing with going forward.
Next question is for Laura from Maureen. What are the recommendations by the healthcare community for employers, faith communities, and other organizations to positively promote the vaccine for the population?
That's a really good question. And it's really important to have groups like that the communities trust and will listen to. And we do have grassroots efforts in place with grassroots organizations to work with the communities to listen to what their fears are, what their concerns are, to make it available and make sure we get to the populations who most need the vaccine. They have to be part of the solution and heard and not just told what to do.
Next question's from Brian. What will be the process by which I learn that I'm ready to get my vaccine? I asked my endocrinologist and he basically had no idea, said I would go to a pharmacy, but do I need some sort of doctor's note to say that I'm in a risk category?
This is a tough question because the situation is so fluid right now. Even at MCW, we're not sure when we're going to get our own vaccine for our 2,000 people that take care of patients. But I expect that it'll be pretty easy going forward once they ramp up the distribution, and that people will know it'll be in the newspaper. You're probably going to, at least for the first 6 months, need a physician prescription before you can get the vaccine. And so you will have to work with either your physician or your other healthcare provider to get that prescription.
Michael asks.
Eric, there's a question here from Melissa that I think would be good if you could answer, take that question.
Melissa, would you like to go ahead and ask Mr. Wesley? Why don't you go ahead with that one? I don't have it in front of me.
It says people with autoimmune disease and those on immunosuppressant medications were not included in the Pfizer trials. The Pfizer materials state that the efficacy and safety of COVID-19 vaccine in this population is unknown. Person is 67 years old, has well-controlled RNA, and is on a biologic. She would like to get the vaccine and is looking for some guidance around whether it's advisable for people in this group to receive vaccination.
Okay, let me just start by saying I'm not giving specific medical advice to a patient, but if you have rheumatoid arthritis or other autoimmune diseases, we still recommend that you get the flu shot. It's very important to do that, and there is an ongoing conversation. I'm pretty sure that the recommendation in the beginning of of calendar 2021 is going to be for people with autoimmune diseases to get vaccinated. That would include people with HIV, people with cancer on chemo and immunotherapy, and folks with autoimmune diseases, but that's still an evolving situation.
Thank you, Mr. Wesley. Next one's from Michael. Is there an issue with the vaccines being delivered? It seems like more doses should already be available.
Laura, do you want to handle that one?
Sure. I know that with the Pfizer vaccine this week, we were expected to receive close to 50,000. And if the Moderna vaccine, when it receives authorization within the next day or so, we were expecting 16,000 doses next week, but I think that has increased. And I think, there is a well-coordinated plan to deliver the vaccines, but they're going to multiple locations. So again, we want to make sure we're equitable with the distribution. And there's 8 hubs across Wisconsin that can receive the Pfizer vaccine and has the capability to store it in the proper, negative 90 degrees or whatever, and then distribute it within those regions. So it's not like all of the doses are coming here to Milwaukee. So it may seem like less, but they're going across the state to make sure we reach our rural populations as well.
Next couple of questions are around access from Sierran. Will community-wide vaccinations be clinic-based at hospitals or community-based like with Miller Park testing, et cetera, or both? Are our area hospitals having this discussion now?
They are, but I think you're part of the public health discussion, Dr. Cassidy.
Yeah, so initially with the Pfizer vaccine and its delicate situation, that's difficult, but as more and more vaccines are approved or authorized, they will be distributed as widely as possible. At pharmacies, Dr. Raymond mentioned drive-throughs. There may be mobile vans delivering it. Some of these are not as fragile and they'll be more available, and the key is to get into the communities to make it as easy as possible to access it, and that is the goal.
And Emily's related question was, would it be available at pharmacies eventually like a flu shot?
Yes.
Next question from Terry, should Black, Latinx, and other minorities be given vaccine priority given their documented susceptibility to COVID-19?
I do think that is part of the plan. It's considered vulnerable. We know that the Latinx population has had the highest burden of disease, while the Black population has had the highest hospitalization and mortality rate. So, that makes them a priority. I mean, we need to protect those in our community who are most vulnerable to bad outcomes.
Next question is from Kelly. Will school faculty and staff be considered essential workers for vaccination purposes?
I do believe they're being considered as essential workers. Now, they're still working out who and how in the rank, but from what I've heard, school workers are essential, teachers are essential.
Next one from Mary is related. When it comes to essential workers, who will be given priority in that group? How are essential workers decided?
As far as I know, that's still being determined. Dr. Raymond, do you have any insight?
Well, I would look to the definition of essential workers at your state level and look back to some of the guidance that we received here in Wisconsin early on about which workplaces were deemed essential and which were not. I think it's easy to say that if restaurants are open, then those would be essential workers, grocery store workers, transportation workers, people in the manufacturing sector that actually have to be on site would clearly be essential workers.
Next one's from Denise. Can you speak to the role of outbreaks in prisons and jails and the impact it has on the community?
Yeah, any outbreak has an impact on the community. And early on in the pandemic, that is where we saw the highest burden of cases. Any institution, a manufacturing plant, or a prison, a nursing home, where people are together in close quarters for extended periods of time makes it easier for the virus to pass. So anytime there is an outbreak or a high burden of disease, it affects our communities.
Eric, if I could just say, we know that we're at time, but we're going to continue to answer questions because these are really important and very sophisticated questions.
We have about 25 questions in the queue, everybody, so we'll try and get through them as quickly as we can. Next one's from Casey. It was my understanding that the vaccine protects you from getting a more serious case of the disease, but does not protect you from getting it. Sort of like the flu shot, you might still get the flu, but it doesn't get as severe. How does the vaccine then protect you from spreading it if you can still get a lesser case?
Okay, great question. So let me just say, yes, there is protection from getting severe case, but it's not exactly true to say that it does not protect you from getting asymptomatic or mild cases. The study have not been done. They haven't been done yet. So that's why the caution about saying, we don't know whether it prevents mild cases, and we don't know whether it prevents transmission out in the community. Again, another reason to wear masks, socially distance, and make sure that you limit the number of interactions you have until we know that. The good news is both Pfizer and Moderna have extended their studies to try to answer that question. And AstraZeneca was doing daily PCR tests to actually measure asymptomatic infections. And so when their study's published, we'll have a much better answer to that question about asymptomatic disease and transmission.
Next one's from Kelly. First, thanking you for this timely and valuable information. The question is, after receiving the second dose of vaccine, is it still possible for me to transmit the disease?
I would say yes, it probably is. Nothing's 100% impervious. And we know that people who have had COVID-19 have measurable antibodies, have gotten infected again. So what I would say is, again, until we have herd immunity, that everybody's going to have to assume that they could still get infected.
Just a quick reminder that the handouts from today are available in the handouts panel for download as a PDF. We'll also include a link to that in the follow-up email that'll go out in a couple of hours to everybody who participated today. We've clustered several questions together that were similar. A number of people are asking, why would you need a COVID vaccine if you've already had COVID? Can you please explain?
Dr. Cassidy, you want to take that one?
Sure. Because this is such a new virus and we don't have a lot of follow-up, we don't know for sure that if you've had COVID-19 that you're protected. And as Dr. Raymond mentioned, there have been cases where people have had it, been diagnosed more than once. And with the vaccine, it's more controlled experiment, not an experiment, but they went through the clinical trials in a controlled environment and targeted specific responses. So in general, over the years, vaccines have been more effective than natural immunity.
And I would say with these vaccines, we know that the antibody response in most people is much stronger from the vaccine than it is from the infection. Like Dr. Cassidy said, that's not a surprise. We've seen that with other vaccines. So you should have better immunity from the vaccine.
Barbara asked if there were anything's being done to mitigate adverse reactions or side effects of the vaccine.
Yes, the recommendation, at least for now, is that people stay for 15 minutes after they get their vaccination, and that the providers have epinephrine, steroids, and histamine blockers, Benadryl, on site to treat any potential allergic reaction.
Tim asks if the rate of spouses getting infected from a positive tested spouse is relatively low, under 50%. Does that mean that herd immunity may be higher than publicized so far?
No, I don't think so, because I don't really think we have herd immunity, and I don't think we're ever going to achieve it through infection, because you can get reinfected. Some people maybe have stronger immune systems. Dr. Raymond can talk to that, but I just don't think that there's evidence for that.
Yeah, I understand the specific question, but I want to answer it more generally. We know that if you do antibody surveillance in our population here in Wisconsin, about 20% of people now in Wisconsin have antibodies to COVID-19. And some of those obviously were in households where somebody had COVID-19, others weren't. So that's nowhere near herd immunity, like Dr. Cassidy said.
Several questions about pregnancy and lactation next. First from Kelly, hoping to hear information about recommendations for the vaccine for pregnant and/or lactating women and children.
The American College of Obstetrics and Gynecology yesterday weighed in. That's the largest organization of physicians that take care of women who are pregnant or postpartum, and they did recommend that the vaccine should be made available to pregnant and lactating women. This is not a regulatory body. This is a society, a group of physicians that are experts that made that recommendation. And hopefully the government will give a little bit more guidance. But what I would say, and I think Dr. Cassidy mentioned earlier, this is something that you certainly need to discuss with your healthcare provider. But I would, if I had a pregnant or lactating family member, I would recommend that they get the vaccine.
Related to that, sorry.
Eric?
Yes, Mr. Wesley.
There's a question here around from Susan, number 52. I'd like you to maybe pick that one up as well. I think that's a pretty relevant question as well.
I'll jump ahead. Thank you, sir. From Susan, if the vaccines all treat the same virus, why are they so different? In other words, -94 degrees versus regular refrigeration, 1 dose versus 2, etc. Also, will it be disclosed which vaccine you get?
You'll know which vaccine that you get. There will be safeguards for that. That's not even a question. I'm not sure that it has as much to do with the differences in the vaccine as it has to do with the conditions under which the vaccines were stored during the the approval process, you have to document very diligently what the storage conditions are before you can get approval. It is possible that for whatever reason, the Pfizer vaccine is quote unquote more fragile than the Moderna, but they use very similar technologies and they use similar ingredients to help you build an immune response. I don't know that there really at the end of the day is going to be a fundamental difference.
I'll go back here to one that's kind of connected. Is there a particular vaccine which is better or worse for a pregnant woman or a woman trying to become pregnant?
We don't know. But both the Pfizer and the Moderna vaccines appear to be very effective and very safe. And again, if it were my family member and they wanted to be vaccinated, I'd say get the first one that is available to you. It's so much more important that we build immunity, both as individuals and as community, than it is about exactly which vaccine we take.
We had a couple of questions about access to information about the vaccine, which you can send to friends and family. Martin asked if MCW had something like that.
Yeah, we've been working on a frequently asked questions document, and it's going through rigorous evaluation. And so we have a group of experts who are compiling answers to questions. We have some of them posted now, but then we are working with different communication teams and community organizations to make sure that the language we use is understandable to everybody and to different audiences. And our communications team is putting together infographics and other information, and then through our various mechanisms, we'll be sharing that because it's very important that everybody has consistent and concise and accurate information. Thank you.
Dr. Cassidy, I did want to make sure that people know we are working on Hmong and Spanish language infographics, but we don't have as many of those as we do for English.
You read Sylvestra's mind. That was her next question. Will there be vaccine information in Spanish for our community? And it sounds like you're working on it. She also asked, what can small healthcare businesses do to get on the list to receive a vaccine more quickly?
Try to get through to the Department of Health Services. I'm sure things will be better very shortly, but as I said, MCW actually has had difficulty. And we have the largest physician practice in the state, even larger than UW. And we still have not received authorization to get the vaccines, but I expect that backlog is going to be cleared up very, very quickly. So do your best to get in line as quickly as possible.
And I know they offer training on how to administer the vaccine, and you can go through the training on how to administer it and record it, and that would be important.
Sierra had another question. How are hospitals and doctors going to make sure people come back for their second dose of the vaccine? And how will they keep track of whether a person was injected with the Pfizer or Moderna vaccine?
Yeah, the state has a very sophisticated tracking system with reminders. And generally the way it's going to work is you'll know which vaccine you get, and to get the second shot, you're going to have to go back to the same place. You will receive text reminders, email reminders, and phone calls. At least that's the way that the framework has been explained to us.
Mr. Wesley, did you want to jump in?
Looks like we're at time, Eric. How many more questions do we have?
We have quite a few, but I think we've got them clustered into just two that can answer a lot if we still have time for that.
Yeah, let's go ahead and do that, Eric. I want to say we'll do our best to try to answer the unanswered questions in our FAQs.
Yeah, and I'll pick that up in the end.
And we also have another community town hall Monday evening, in case this wasn't enough.
That's right. I'll encourage everybody to come back Monday evening if you still have questions unanswered. Question from Kate. If people fail to come back for the second vaccine, is there a window of opportunity to receive it, or do they have to start over again?
Excellent question. I don't think there's a good answer. The general advice that I've heard is you can maybe slide a couple of weeks and still get the second shot. But if you wait longer than that, I'm really not sure what the advice is going to be.
Yeah.
And last question from Lori before we wrap. I have a friend who's experiencing longer-term residual effects from the virus. Where should she go to find resources or help?
I would start with her primary care provider. The larger health systems are already developing clinics for the COVID long haulers. And I'm sure that the federally qualified health centers are also working on that problem as well. So I would start there. You can also Google long hauler or long COVID to find self-help groups that may be able to give you more information in your local region.
And with that, I'm going to say thank you all for your questions. I want to reiterate our goal is to bring you the most up-to-date information, accurate information regarding the COVID-19 vaccines. Thank you to Dr. Raymond, Dr. Cassidy. Thank you to the community for being here today. Please note that if we did not get to your questions, we'll be reaching out to you directly. We do have your information, as well as answering questions on our FAQs, which is on covid19.mcw.edu. We'll do our best to answer your questions as clearly and as directly as possible. Again, I say thank you for joining us. Happy holidays to all, and tune in on Monday if you can, and encourage others to become as informed as possible about the COVID-19 vaccine. Thank you.
Thank you.
Thank you. Thanks, Eric.